Hello, and welcome to our review of the lupus literature for July. We record these podcasts for you every month, so you can always keep up to date on the latest literature and our expert opinions. I'm Ed Vital, I'm chair of the Lupus Forum. I'm from the University of Leeds, and I'm once again joined by Professor Vibeke Strand, who's an adjunct clinical professor at the Division of Immunology and Rheumatology at Stanford University School of Medicine in California. Welcome.
Thank you. It's good to be here.
So today we're looking at key publications from July and that we covered on the forum. And we've chosen two of them for the podcast, only two, but they're both pretty big papers. And so one of those is a clinical trial, which I'm going to look at first, which is about upadacitinib and elsubrutinib. And then we're going to come to the study that you looked at about LLDAS. So on to this trial, first of all. So this is an interesting concept for a lupus trial because it includes two drugs in this sort of factorial design where you could have one, the other, both together, and even two different doses. And the two were chosen for quite interesting reasons. So one thing I talk about quite a lot is that we have a load of therapies that target B cells, and we think that's important for lupus. But there's other aspects of lupus where targeting the innate immunity is more important, like a lot of the skin manifestations you see in lupus, not really so responsive to B-cell therapies, but super responsive if you block type 1 interferon. So that's what this sort of combination design is getting at here, because we're testing two drugs. One of them is upadacitinib, which lots of people know already, got lots of licensed indications already. It's a JAK inhibitor and it's selective for JAK1. Selective for JAK1 means that it blocks type 1 interferons, gamma interferon, IL-6, and some other cytokines. The other drug is elsubrutinib, which is a bit less familiar to rheumatologists, but will be very well known to hematologists. So it's a BTK inhibitor, so it blocks signaling through the B-cell receptor. And there are lots of these drugs, and there are lots of them because they're really useful in treating some of the B-cell malignancies, where it's actually quite important to have a range of them as well. So if you block B-cell receptor signaling, you should stop activation of the B-cell. And so is that combination, block JAK1 on one hand and BTK on the other, a good idea? So what they did in this trial was they started with 5 arms. This is a phase 2, 48 weeks, but it had 5 arms. About 65 patients in each of those arms as it started. And those consisted of these combinations. So one is the combo. The name for the combo is ABBV 599. So ABB 599 in a high dose. High dose means elsubrutinib 60 and upadacitinib is 30. Then the next one is the combination again, but with a lower dose of upadacitinib. So elsubrutinib 60, upadacitinib 15, a more familiar dose. And then the next arm was elsubrutinib 60 on its own. The fourth arm was upadacitinib 30 on its own, the higher one. And the fifth arm was placebo. So we've got all those arms started, an endpoint of SRI-4, but it's SRI-4 with prednisolone less than 10. Because I think our impression from lots of trials is if you're not reducing steroids in a fairly mandated way, then you can get high placebo response rates. So halfway through the follow-up, there was a planned interim analysis. So an independent group of people analyzed the data from these 5 arms. And at that point, they judged that on those data, 2 arms should be dropped. Those 2 arms were the low dose of the combination therapy and the elsubrutinib monotherapy arm. So those 2 got dropped, and the ones that continued were the high dose combination, that's with upadacitinib at 30, and the upadacitinib 30 milligrams monotherapy, plus placebo, of course. So at 48 weeks, the result was that both of those active arms, both containing upadacitinib 30, but one of them also containing elsubrutinib, were superior to placebo across pretty much all the endpoints. So some of those are shown on the screen there. So for the primary endpoint for SRI4 and lower dose glucocorticoid, both significantly superior to placebo, SRI4 on its own, BICLA, LLDAS, flare reduction. Joint counts and class E, there was a little bit more variability because some of the numbers of patients who are analyzable getting reduced a bit for those. Double-stranded DNA and complement both improves, interferon signature comes down. So the main conclusion from this is that upadacitinib seems better than placebo, but combining upadacitinib with elsubrutinib doesn't seem to add anything else. Safety looked kind of okay, but there was a slightly higher serious infection rate in the active arms than in placebo, with a bit of zoster in there, as we see for the other innate therapies that you get in lupus. So what does that mean? Because BTK inhibitors seem to make an awful lot of sense in a disease like lupus. But actually, so the upadacitinib data is that result is exciting, and that's going into phase 3. But the BTK inhibitor result is a bit disappointing, and it's not the only one. We've already had negative trials, which I think we've talked about some of them here, of fenbrutinib, branabrutinib, evobrutinib, which would suggest that maybe BTK inhibition is, for some reason, not the best way to target B cells. And there may be a reason for that. And some of the mechanistic data with B cells, which I know Thomas Derner and his colleagues have looked at in a great detail recently, have suggested that maybe in the chronic disease, the B cell receptor signaling isn't as important. That there are other ways B cells can get activated. There's T cell activation by the CD40, toll-like receptors, interferon activates them. And in this chronic state, maybe the B cell receptor isn't so important. And that's a kind of interesting observation, because if you have a long memory, there was a drug called efrotuzumab, which targeted CD22, which is also a molecule that's meant to modify the B cell receptor signaling. And it also led to a negative trial. So that's maybe something interesting that we need to learn. When you want to target B cells, you can't just block the B cell receptor. Maybe you've got to target the B cell as a whole with belimumab or rituximab or obinutuzumab or ianalumab or something like that. So this is a trial of a drug that we always use in the clinic that looks like might be progressing into phase 3 and then hopefully a license. What did you think?
Well, it may be, but
Maybe.
we've had several JAK inhibitors that have been in phase 2. And then we, of course, have baricitinib that went into phase 3. And one trial succeeded barely, and the other one failed completely.
Yeah.
So this is very interesting that upadacitinib may be different. And we've seen some limited data with tofacitinib in lupus as well, which was promising.
Yeah.
So what would be different about upadacitinib from the other JAKs? And of course, then we could talk about the TYK2, deucravacitinib, which seems to be quite promising in lupus and different.
Yes, that's a very good point, that a lot of these trials we get excited and then they don't succeed, and the JAK inhibitor field may be a more challenging part of that. What's different, I suppose, I mean, JAK1 and TYK2 are focusing in on interferon signaling, which may be how these work.
Right.
But that's a tried and tested mechanism, and that their effects on other cytokines aren't as important. So that'd be one thing that's making those filter through. It also may be that there's always improvements in trial design and differences between how the trials are done. Because baricitinib had great phase 2 data as well, didn't it?
Yes, it did. It did. But this is common in lupus. Phase 2 trials that are done in more limited populations across fewer countries, maybe less heterogeneity, tend to be positive, and then one gets into much more challenges with phase 3, even with anifrolumab, that of course is now approved.
Yeah. So then perhaps that is a good segue into talking more about endpoints that we need to achieve in trials, which is what the subject of this paper that you took a close look at.
Yes, so this is the association of the clinical endpoint, lupus low disease activity, and the longer it's sustained, how much better are the outcomes. And this is from the Australasia or Asia Pacific group led by Eric Morand, and they've given us a lot of good data. And LLDAS is already accepted as a good clinical endpoint. And it's something that's meaningful because it's a limited amount of use of steroids and immunosuppressives or immunomodulators. And it can be attained, whereas DORIS remission, it tends to be a much more stringent endpoint and harder to attain. So even though it's not become a regulatory endpoint, most trials include LLDAS because of its clinical meaningfulness. So this was looking at the protective association of relatively short versus long-term periods of time in LLDAS. And it was in a very large patient population. So it was prospective from May of 2013 to December of 2020, multinational, longitudinal. They were all over 18, but with active lupus. And the primary outcome was the accrual of more organ damage, irreversible damage, defined as at least a 1-point increase in the SDI. And what we see from this figure, which is a little hard to read, is that you're looking at intervals from 0 to 3 months, 3 to 6 months, longer than that, 12 months, and so on, all the way to those who stayed in LLDAS for at least 6 months. And that is the red line at the bottom, which really clearly shows that the damage accrual from just short-term LLDAS is quite dramatic over time. And yet when one stays in LLDAS, there's much less accrual of damage over time. And it's quite statistically significant. So what we can see is that the duration of sustained LLDAS by dose effect was demonstrated quite clearly. And it's obviously then a goal to try to have patients stay in LLDAS for as long as possible. And the best results here being demonstrated by having been in that clinical remission definition for 36 months or longer. I think this is quite interesting. Again, we don't really know the degree of baseline damage or even disease activity in this entire group. And I think we all feel that there are some milder populations of lupus where it's much easier to accrue LLDAS as opposed to those who may present with really dramatic disease. And then we are able to improve them, but oftentimes we are fearful that they're going to flare again. So I don't know what you think, Ed, but
Yeah,
it's a
that's
great
right.
goal.
I mean, going back to our conversation about trials, it does make me think sometimes that the approach we take to something like this, like we're trying to predict mortality in a routine care population in the clinic, is a bit different to what in trials we look at response, don't we? We're just looking at 0 versus week 48, just those 2 time points. And in between those, physicians adjusting steroids and people having flares and things and dropping out of the trial because their flare was so bad and stuff is kind of like regarded as sort of noise that messes up the data, isn't it? But actually, what this is saying is it's not really about this time point versus that time point. It's about the duration. That's what matters.
Right.
In fact, they think they even say in this paper, don't they, that the differences between LLDAS versus remission versus steroid-free remission and perhaps versus LLDAS with 7.5 of pred or 5 milligrams of pred aren't that important. What's really important is how long you're on target for.
Right, I agree. And I think one of the other things is that people have learned that in order to get results in randomized trials in lupus, you've got to accrue patients with fairly significant disease activity.
Yeah.
And if you don't, then you won't see change. And so we end up looking for SLEDAI and BILAG scores of activity, as well as low complements and elevated dsDNA antibodies. And that defines a very specific population.
As you said, the explanation for this, most of these papers about LLDAS are observational studies.
True.
We don't really have treat-to-target trials yet. So a lot is the explanation for this association all about give more treatment, give more drugs, lower the disease activity, and that'll give you a good long-term outcome. In which case, what it probably tells me I should do is be more aggressive with my immunosuppression. Or is this association because some people are just predestined to have a mild course as well as less damage, and other people just with, they've just got mild, a little bit of arthralgia or something, not too much, whereas other people have a lot of internal organ involvement. And I don't know whether me being more aggressive in immunosuppression is necessarily able to normalize. It might improve their long-term risk of damage, but I might not be able to bring it down to the same level as your mild patient.
Well, we all remember our patients who had very severe disease, and then they were treated and they became relatively stable and quiescent, and then suddenly flared terribly. And I can remember several of those patients that I lost almost in the same week.
Yeah.
So I think lupus remains a bit unpredictable, even though we have more measures and we have better ways of following patients.
Yeah. Because if, I mean, it can be both those things, can't it? But if it's the first one, it's all about optimizing immunosuppression and always increasing immunosuppression until you hit remission. But if it's the latter one, there's a kind of, you've got a more severe phenotype, it's just kind of predestined, you're going to have more problems over time, then actually it becomes more about recognizing that person and stepping in with other things you can do to prevent damage, like cardiovascular risk and things like that. Perhaps.
True enough.
Okay, so great. Well, that's about all we have time for today, but those are two great papers. Thank you for joining me, Vibeke. It's great to hear your thoughts on these developments.
Yes, good to be with you, and I'm excited about upadacitinib.
Yeah, and thank you everyone for listening. As always, the slide decks for these papers are on lupus-forum.com. You can download those for free and use them as you want. And if you register for updates on the Lupus Forum, then you'll get emails whenever there's new content available, or you can get that by following us at Lupus Forum, or one word, on Twitter or LinkedIn. Thanks again, and see you next time.
Bye-bye.